How are you, Dr. Herman? Nice to
Good.
see you.
Nice to see you as well.
Thank you, everybody, for joining us. My name is Susan Lautenbach. I'm a volunteer for Epilepsy Awareness Day at Disneyland, as well as an employee for SK Life Science. And it is my pleasure this afternoon to introduce you to Dr. Herman. Dr. Herman is a professor and vice chair of neurology and director of the Comprehensive Epilepsy Center at Barrow Neurological Institute in Phoenix, Arizona. Dr. Herman specializes in treatment of difficult to control epilepsy, including new medications, epilepsy surgery, and devices. She is president of the National Association of Epilepsy Centers. She co-leads the Epilepsy Learning Healthcare System, a national network of epilepsy centers, advocacy organizations, and patients and families who are working together to improve epilepsy outcomes. Thank you so much, Dr. Herman, for joining us virtually, hopefully live next year, but virtually this year. And Dr. Herman will be talking to us about the newest seizure rescue meds, as I mentioned before. Dr. Herman, I'll be monitoring your chat if something comes up, and then you can decide if you want to have me stop you or answer it at the end, whatever you would like. But I will definitely keep an eye on the chat. So for any questions, please use the chat. Thank you so much.
Excellent. Thank you so much. Can you see my slides okay?
Yes, I can.
Perfect. All right. So I think we can all agree that we would be much more excited if this were actually in Disneyland, but I can promise you I will not be quite as entertaining as the teacups. So I'm going to talk today about seizure action plans and rescue medications. And there's quite a few new treatments available to treat seizure emergencies. So I'm going to first talk about how to recognize seizure emergencies and then talk about some of the new treatment options that are available. So this audience is very familiar with the definitions of seizures and epilepsy. So seizures being a sudden temporary disruption of brain activity caused by abnormal electrical activity. And what we see or what the person experiences during a seizure depends on where in the brain the seizure activity begins and how that seizure activity spreads in the brain. Epilepsy, on the other hand, is a disease of the brain that's defined by having recurrent seizures, at least 2 unprovoked seizures at least 24 hours apart, or 1 seizure and a high risk of having further seizures. And many of the people I'm sure who are on this call have a long history of seizures and have had very frequent seizures throughout much of their life. And that is the group of people who can be most helped by rescue medications. I'm not going to go through all of the details of this, but I just want to orient everyone to the fact that there are 3 main classes of seizures. There are focal onset seizures. These are seizures that begin in one area of the brain, and the symptoms that a person experiences depends on where in the brain it begins. So if it starts in the vision area, you might see lights or colors. If it starts in the movement area of the brain, you might have jerking or twitching of an arm or a leg. If it starts in a part of the brain called the temporal lobe, you may have an unusual memory like deja vu or an intense sensation of anxiety. When you work with your doctor to determine what types of seizures you have, they'll ask a lot of questions about the symptoms that you experience at the beginning of the seizure. Other focal seizures don't really have any warning. The person just becomes confused and may stare and be unresponsive. Those are seizures with impaired awareness at onset. Generalized seizures, on the other hand, begin in the whole brain at the same time. And the 2 main types of those are absence seizures, where the person suddenly loses awareness, may stare, may have some eyelid flickering. They're very brief, 10, maybe 15 seconds, and the person wakes back up and goes on with their normal activities. The other major type in this group are generalized tonic-clonic seizures, and these begin with a sudden loss of consciousness, stiffening of the body, often a loud cry. The person may fall and have shaking of the arms and legs, lasting between 30 seconds and a couple of minutes. And these seizures, of course, are more dangerous because they may result in a fall with risk of injury. And then we have some seizures where we don't really know where they begin in the brain, but we describe them by their symptoms. There are a lot more details about different seizure types. So if your seizure type isn't on this list, don't worry, we can deal with that in the question and answer session. So I talked about all of this. So seizure emergencies fall into a few different classes. So the first I already mentioned. So these are seizures that result in falls or injuries. So people may experience fractures, head injuries, burns from hot items or from cooking, cuts or lacerations, bruising, injuries to the teeth or the tongue or the gums. These are most common with seizures that are generalized seizures where people suddenly stiffen and fall, but can occur even with focal seizures, particularly if people continue to do their normal activities like cooking or walking around, and they may risk tripping over things or falling during seizures. The second type of seizure emergency is prolonged unresponsiveness or confusion or unusual behavior that comes after a seizure. So I mentioned before that many seizures last just a couple of minutes, and people generally recover back to their normal activities within 5 to 10 minutes after a seizure. But in some cases, people may be confused for a much longer period of time. They may become very agitated or upset, may even develop very unusual behavior. And these symptoms occurring after a seizure can also be quite dangerous. I'm not going to spend time today really talking about those seizure emergencies. We're going to focus on seizure emergencies of seizures that occur too often or occur and are very prolonged. So we'll first talk about seizure clusters. These are seizures that occur in a group, usually over the course of a few hours or a day, and it's more than a person's usual number of seizures. Prolonged seizures, which are seizures that last more than 2 minutes, or for any particular person, a seizure that lasts longer than usual. And then finally, status epilepticus, which is a medical emergency where seizures last more than 5 minutes, or there are recurrent seizures without the person waking up in between the seizures. So let's talk about these in a little bit more detail. So I'm really going to focus today on giving some tips on how to prevent and manage seizure emergencies. So this is the outline for the rest of my talk. First, to know your triggers and avoid them if you can. Use a medical alert, so jewelry or phone that has your diagnosis on it so that other people know that you have a history of seizures. And then use a seizure or a fall alert device, so something that could potentially notify other people that you're having a seizure. And there's a few different options for this. There are special fall alert devices. I've fallen and I can't get up kind of devices. There are other fall alerts. For example, the iWatch has a special alarm that if you fall and you don't turn the alarm off, it will call for medical personnel. And there are some specialized seizure alarms that can be used either wearable or on a bed or a chair to alert someone if a person is having a seizure. But the two most important things that you can do are to have a seizure action plan. So what to do if you have a seizure, and in particular, if you have more seizures than usual, and talking to your provider about rescue medications, whether you need one and how to use it if you do need one. So I talked a little bit about triggers. The triggers for seizures can be different from person to person, but this is a list of some of the common seizure triggers. So some people have what we call reflex seizures, so seizures that occur in the when a certain change happens in the environment. So for example, flashing lights, some people are sensitive to strobe lights or certain patterns on television or on video games. Some people have seizures that are provoked by sound, like music or loud noises can often bring on a seizure. Other medical illnesses, so if you're sick and you have a fever, or you have nausea and vomiting and you can't keep your medications down, that can be a really significant trigger. Alcohol, particularly heavy amounts of alcohol, and suddenly stopping alcohol if you drink on a regular basis. Drug use, particularly cocaine and methamphetamines, can result in seizures, and withdrawal from medications like opiates and benzodiazepines, sort of downer medications, can also cause seizures. Sometimes other medications that you're taking for other medical conditions can cause seizures. These include some cold over-the-counter medications, certain antibiotics, certain medications for mood. So it's always useful to talk to your doctor about what other medicines you're taking and whether those could have an impact on your seizure. Probably one of the most common reasons for seizure triggers is missing doses of seizure medicines. We'll talk more about that in a second. Some people only have seizures while they're sleeping. Others are more likely to have seizures when they're sleep deprived, when they stay up too late, or if they suddenly have to wake up early in the morning, that can bring on a seizure. Hormones, so for women who have epilepsy, some have seizures at certain times of the menstrual cycle. We call that catamenial epilepsy. And seizures tend to occur right at the beginning of the menstrual period and around day 14 during ovulation. For some people, stress can be a trigger for seizures. That's probably one of the ones that I hear most commonly, and rarely seizures can even be provoked by exercise. So I'm just going to take a quick poll here. You guys can type into the chat if you have any seizure triggers, or the person in your life who has seizures has a trigger for their seizures. We'll just get some idea of whether. Hormones, sleep, and stress, lack of sleep.
Yep, there you go.
Yeah, those are some of the most common for sure. All right. So I wanted to spend just a minute or two on missed seizure medications, because again, this is one of the most common reasons. And sometimes the person who is taking the medicine doesn't even know that they're missing doses. So unless you have a system set up to say whether you took your medicine on a particular day, you may not even realize it. I kind of compare this to whether I remember every day which floor I parked my car on, because I know I park my car every day, but where did I park my car today? And often that can be the situation for people who are taking medications on a chronic basis. You know you take your medicines every day, but did I take them today? And so using things like a pill box or some sort of a calendar that you can check off when you take your medicines is a good way to keep track of that. Patients with seizures often have memory problems, so forgetting doses of medicines is not uncommon. Some of the medicine schedules are really complicated, and the instructions can be very confusing. And so people make errors and miss doses because of the difficulty in understanding the directions. Sometimes we recommend that people make a change in their medications. We cut down their medicines because they're having side effects, and that can result in seizures. Everyone knows that it can be very difficult to get medications from the pharmacy, particularly if you don't drive. And so having trouble getting a steady supply of medications can also be a problem. Sometimes patients feel they don't need their medicines. They weren't working, they're causing side effects, and they just don't feel that they're being helpful, so they may stop them on their own. And I would encourage everyone to please discuss that with your provider before you stop your medications, because there's safe ways to stop medications and not so safe ways. And then finally, sometimes you're unable to take your medications by mouth. You may have a procedure coming up, or surgery, or a colonoscopy, or you're sick and have nausea and vomiting and can't take medication. So these are all times where missing medications may result in a breakthrough seizure. About half of people who take chronic medications do not follow the instructions exactly. And unfortunately, for patients who have seizures, it's important to keep a steady level of the medications in the blood. Missing even a single dose of medicine can sometimes result in a breakthrough seizure, not always. Whether or not somebody has a seizure after missing a dose of medicine depends on how severe their epilepsy is, how many doses they miss, how big a dose they miss. If they're taking multiple seizure medicines and miss them all, they're more likely to have a seizure. But stopping medications entirely or missing more than one dose at a time often results in breakthrough seizures. And these seizures may be more severe than the typical seizures and may result in prolonged seizures, seizure clusters, or even status epilepticus, which, as I mentioned, is a medical emergency. I'm going to skip some of these here and just go on to seizure clusters. So who's heard of seizure clusters? Anyone?
I have.
Excellent. So seizure clusters have a bunch of different names. Sometimes they're called acute repetitive seizures or recurrent seizures or repetitive seizures, but I think most of us now call them seizure clusters. So seizure clusters are seizures that themselves are not exceptionally prolonged. They typically last less than 5 minutes, and in between the seizures, the person wakes up and is back to normal alertness and can interact. So this is a little different than status epilepticus, where the person doesn't wake up in between the seizures. And we describe a seizure cluster as a change in a seizure pattern in somebody with epilepsy. The seizures are either more severe, or they're more frequent, or they're more prolonged. So all of those things can be signs of a seizure cluster. So a typical example might be, a woman who has seizures. Typically, she has one seizure a month. She has brief staring spells. They last up to 30 seconds. She's back to normal within 2 minutes. But around the time of her menstrual period, she'll often have 3 or 4 seizures in a day. The seizures last 2 minutes. She can be confused for up to 10 minutes after them. So that would be a seizure cluster. Those seizures all occur within 1 day. She wakes up in between them and can do her normal activities, but the seizures are very different from her usual seizure pattern. And the clusters themselves can last for several minutes, up to several hours, or even over a couple of days. So why are seizure clusters important? So first, about half of people with epilepsy will have at least one seizure cluster. And 75% of people who have at least 4 seizures a year will have a seizure cluster. And these seizure clusters are likely to recur. So once you've had one cluster of seizures, you're likely to have more unless your medications are adjusted or you have a medication to take to stop the clusters. And seizure clusters are much more likely than individual seizures to result in a visit to the emergency room or to the hospital. Risk of problems with breathing and heart rhythm abnormalities after a seizure. Much more likely to have a prolonged recovery, so more time before the person is back to normal with changes in mood or memory or behavior. And more than half of clusters can progress to status epilepticus, which can be very dangerous. So once you've had a seizure cluster, this is definitely something that your provider should know about, and you should have a discussion about whether you need to have a medication on hand to stop seizure clusters and prevent some of these potentially serious complications. Now, status epilepticus is continued or prolonged seizures where the person doesn't wake up between the seizures, or the seizures are continuous, lasting at least 5 minutes. And in the past, we used to say seizures had to last 30 minutes before we would consider it to be status epilepticus. But over the last 20 years or so, we've shortened that definition to be 5 minutes. So we know that most seizures will stop on their own within 2 minutes. If they don't stop within 5 minutes, then that seizure is unlikely to stop on its own, and emergency medical help should be sought for that seizure. And status epilepticus is pretty common, up to 100,000 cases per year in the United States. Again, at least 15% of people with epilepsy will have at least one episode of status epilepticus. Luckily, most people do fine with medical treatment after status epilepticus, but they're more likely, just like seizure clusters, to have more than one episode of status epilepticus. And just like seizure clusters, they can result in breathing and heart problems. Many times the person requires hospitalization and oftentimes requires intensive care, may need to be intubated, have a breathing tube put in, and may be on a breathing machine for a period of time. And between 3 and 5% of patients with status epilepticus may die either from the seizures themselves or because of complications of treatment. If the seizures are very difficult to treat, then the risk of dying from status epilepticus is much higher. Luckily, people who have epilepsy have a lower risk of difficult to control seizures than other causes of status epilepticus, but it's still something that can be quite medically serious. Okay, so when I talk to my patients, we go through sort of a structured evaluation to determine whether they're at risk for seizure emergencies and what we should do about it. So you can answer this list for yourselves. So you're at risk for seizure emergencies if you've had a previous seizure emergency, either seizure cluster or status epilepticus, especially within the past year. Give yourself 1 point for that. You take more than 2 medicines at the same time to treat your seizures. You often miss doses of your medication, either because of forgetting or because you don't have a system to take your medications regularly. You've had epilepsy surgery and are continuing to have seizures, or you've had a device to treat your seizures, but you're still having seizures. And then certain types of epilepsy. For example, in the last talk, we talked a little bit about Dravet syndrome and some of the other very serious types of epilepsy in children. And those seizures have a much higher risk of seizure emergencies than most people with epilepsy. So each one of these gets 1 point. And if you have 4 or 5 points, then you're at pretty high risk for seizure emergencies. So the next step in dealing with seizure emergencies is to create a seizure action plan. And this is done in combination with your provider, whoever's taking care of your epilepsy. And it's basically written instructions about what to do in case you have a seizure. What to do if you have a seizure trigger. Is there anything you can do to prevent having a seizure? If you have a warning, how should you get to a safe place? And what might you do in terms of notifying other people? What should be done in terms of first aid? What can you tell your friends and your family, your schoolmates, your coworkers about what to do with the seizure? And then specifically, what you should do and what other people should do if your seizures are longer than usual, more frequent than usual, don't stop on their own, or if you don't wake up after a seizure. And all of these things can be really critical to determine beforehand, because when you're in the middle of an emergency, you're not going to be thinking clearly. The people around you may not remember exactly what to do. So it's incredibly important to have this written down and to have it in a place that's available for people to review in the case that you have a seizure. All right, so who has a seizure action plan? All right, we see a couple of people who have seizure action plans. All right, after my list of things, who thinks they should have a seizure action plan? Excellent. All right. So let's talk a little bit about what's in a seizure action plan specifically. So the first is information about your epilepsy team. So contact information for the person with epilepsy and their caregivers, any other emergency contacts, your primary care doctor, your epilepsy doctor, and then where you would prefer to go to the hospital, the emergency room, or an urgent care center if there's a seizure emergency, and then information about your pharmacy. Next, your seizure types. I went over seizure types at the beginning, the name of the seizure, what you call it, and if possible, what your healthcare provider calls it, how long the seizure usually lasts, how often they usually occur, and a description of what happens during the seizures. Because remember, seizure clusters and status, you tell whether they're happening because they're different than the normal seizures. So the people who are helping you need to know what your normal seizures are like. Information about your daily medications, the name of the medicine, the amount and how you take it, the time of the dosing and how much. And then any other information that you think might be important, triggers, allergies to medications, whether you're on any other treatments for epilepsy. These things are helpful, but they're not always essential for a seizure action plan. Then there's information about first aid. And many of you may be aware of this graphic from the Epilepsy Foundation, which you can find at epilepsy.com, which is stay safe side. So stay calm, keep calm, time the seizure. Remember, I talked about long seizures are often a sign of danger. And so you want to know how long each seizure is lasting. Keep me safe. So move things around from around the patient. Try to get them to a sitting or a lying position if you can do that. Don't hold them down at all and protect their head. And then side. As soon as you can, turn the person on their side if they're not awake. Make sure there's nothing in their mouth. Don't put anything in their mouth. Keep their mouth and nose clear. And then stay with them until the person is recovered from the seizure. Other information that may be important is to notify the emergency contact. Patients who have devices like a vagus nerve stimulator, you may want to swipe it. You may want to use the magnet for the responsive neurostimulator or the deep brain stimulator to record when the seizure happened. You may want to jot down what happened during the seizure, how long it lasts, how many. In some cases, you want to give a rescue medication, and I'll talk quite a bit about that. And there's additional information about all of the first aid information at these websites, which we'll make available to everyone. All right, so when should you call your provider about a seizure? So anytime there's a change in the seizure type, number, or pattern, your doctor will want to know so that they can discuss with you whether any changes in therapy should be considered. If you haven't had a seizure for a long time and a seizure suddenly comes out of the blue, then you want to let your provider know. Any seizure clusters, prolonged seizures, repetitive seizures, anything that makes you go to the emergency room or be hospitalized, your provider wants to know about that. If you have to use a rescue medication, and oftentimes your provider will say, you know, if you have to use your rescue medicine more than once a month, or more than twice a month, or more than 4 times a month, depending on how often you have seizures, they may want you to call them if you're using the medications very frequently. And then finally, if you have a seizure different from your usual seizure, and you should talk to your doctor about whether there's any other times that you should let them know when a seizure happens. When should you call 911? So typically we would say a seizure with loss of consciousness lasting more than 5 minutes. If you have a rescue medication, you want to give a couple minutes for that to work. But again, if you give a rescue medicine and the seizure is still continuing after 5 minutes, that's a time to call 911. If somebody has a series of seizures and isn't waking up in between them, again, more than 5 minutes, call 911. If the person seems to have difficulty breathing or seems to be choking or has any problems with their heart rhythm, call for emergency help. If the person isn't waking up or at least starting to wake up within 10 minutes after the seizure. If the person has been injured or if the seizure occurs in water, that could be quite dangerous. So you want to call 911. And then finally, if the person with the seizure is pregnant. Your doctor may have other recommendations about when to call 911. That can be individualized, but these are the general rules of thumb for when there's a medical emergency and when you should consider calling for emergency help. An action plan may also include what to do after a seizure. So like I said, what type of help do you need? Do you need to call for emergency help? When can you go back to your normal activities? When can you return to school or to work? If you do need to call 911, what should the emergency personnel do? Does your doctor have specific recommendations for what medications the emergency medical service should do? And then if you get to the emergency room, are there specific recommendations that your doctor would have for the emergency room personnel in terms of treating your seizures? So this can be really, really helpful in having a a standardized plan for what will happen if you do have to go to the emergency room. And then finally, there may be some specific situations that you would want to include in your action plan. So what would happen if you had a seizure at work? Do you have to go to the hospital? Do they have to call emergency services? Do you need time by yourself to recover after a seizure? Should you be supervised for a period of time? Same thing for school. What are the activities that should be done in a school seizure situation? Similarly for day programs and instructions for babysitters or other caregivers. So there may be more information that's needed when you're out of your house and away from your typical caregivers. All right, so that was a lot of information. So if you guys have questions, you can start typing them into the chat box. Now I'm going to switch gears and talk about rescue medications. When we typically think about giving rescue medications, there are a few different times that we might consider. So first, sometimes we give a rescue medicine to try to prevent a seizure. So some of you said sleep deprivation is a big trigger for you. So you wake up in the morning and you're feeling off, you didn't have a good night's sleep, you know that every time this happens, you have a seizure. Is there anything that can be given at that point so that you won't have a seizure that day? Sometimes that will involve maybe an extra dose of your regular seizure medicines. Sometimes it will include some of the rescue medications that I'm going to talk about. The times when we typically think about rescue medications are if somebody's having a seizure cluster, having a prolonged seizure lasting more than 2 minutes, or having a certain number of seizures with loss of consciousness without waking up between them, usually 2 or more seizures. But there's a lot of details. What kind of seizures do you take a rescue medicine for? What medicine? What dose? How do you take it? What to do if the seizure doesn't stop after the rescue medicine? And so this decision about how and when to use rescue medications can be really, really complicated. And we did a small study at our center looking at how long it takes to go through all of the different situations where you might use a rescue medicine and make sure that the person with epilepsy and their family and caregivers know what to do in this emergency situation. And it's about 30 minutes. 30 minutes of one-on-one time going over the rescue medicine and seizure action plan to get it right and be sure that when you're in a seizure emergency, you know what to do. So this can be pretty complicated, and we'll go through some of the decision items now. So as I mentioned, seizure rescue medications may prevent seizures after a trigger or after you've had a small seizure like an aura. It may shorten seizures. The longer a seizure lasts, the more difficult it can be to treat. Sometimes rescue medicines, if they shorten seizures, can reduce the after effects of a seizure. They may make you less confused or have a shorter duration of unresponsiveness. In some cases, they may prevent you from having to call 911 or go to the emergency room. And most importantly, they may prevent status epilepticus. All right, this is a list of different things that the physicians and other healthcare providers will consider when we're choosing a rescue medicine. Which medicine is it? How well does it work? How effective is it in stopping seizures? How long does it last? So that involves both how long should we expect it to prevent seizures, and also if there are any side effects, how long will those side effects last? How often can we give the medication? What are the possible side effects? And if there are any serious side effects, what are those and how do we minimize those? How easy is it to use it? Can it be given quickly in the setting of an emergency? Does someone else need to be there to give the medicine, or is this something the person with epilepsy can use on their own? What kind of medicine is it? Is it a pill? Is it a liquid? Is it injection? Is it a spray? Can you carry it with you? Do you have to put it in the refrigerator? How long can you leave it before it expires? And how expensive is it? So these are all of the things that we would typically review with you when we're choosing a rescue medication. The most common medications are medications called benzodiazepines. These are medicines like lorazepam, Ativan, diazepam, Valium, midazolam, Nasolam. And these medications can be given either by mouth, rectally into the rectum with a syringe, intranasal using a nasal spray, sublingual under the tongue, buccal, a liquid that goes between the teeth and the cheek, intramuscular, injected into a muscle, or intravenous, injected into a vein. Now you can tell that probably these injections are not something you could do at home, but most of the others can be done at home. And there are available types of these benzodiazepines to be given by all of these different routes. But which one is most acceptable to you? Most adults, I would think, would not be all that excited about a rectal medication, particularly if they have seizure clusters in public. Sometimes we don't want to use a liquid medication because the person may get that down into the lungs or choke on the medication. So there's a lot of things to consider before we can choose one of those medications. The most common are liquids. So these are a couple of the liquid forms, lorazepam and diazepam intensol. These are concentrated liquids where you only need a small amount, so the risk of choking is decreased. And then buccal midazolam, which is almost like a gel-like midazolam that goes between the cheek and the teeth. And these are all commonly used for seizure emergencies. Some of them require refrigeration and carrying around a liquid that you have to measure out at the time of a seizure emergency can be difficult. There are also some pills. The most commonly used are lorazepam under the tongue, sublingual lorazepam, or clonazepam, which comes as a tablet that is kind of powdery and dissolves very quickly within the mouth. And the advantage of all of these medicines by mouth is that they get absorbed right through the gums into your system. They don't have to be swallowed and go through the stomach and get absorbed. So they work much more rapidly than a medicine that you swallow. So these medicines shouldn't be swallowed. They should be put into the mouth and absorbed through the mouth. However, these may need to be refrigerated. They're difficult to deal with. You might spill them in the middle of a seizure emergency. They can take several minutes still to have an effect, and you may not be able to use them during a seizure. The next commonly used rescue medication is rectal diazepam gel. This is sold sometimes under the brand name Diastat. This works quite quickly. The dosing is different depending on the age of the person. So it's based on the weight of the person with a certain amount of the medication per kilogram per dose. And this is put into a special type of syringe and locked in so that at home, you're only able to give the dose that was prescribed. And the side effects are fairly mild. They include sleepiness, rarely breathing problems, slow breathing rates, and very rarely allergic reactions or rashes. So this is what the Diastat looks like. There's this little syringe. The pharmacist prepares it with a certain amount of medication in it. You take off the tip, put the tip into the rectum, depress the plunger, the medication goes in, you hold the bottom cheeks together so the medicine can't run out for a minute after giving the medication. And this usually has an effect within just a few minutes. However, it can be difficult to give this while a person is having a seizure, particularly if they're having a convulsive seizure. You need to be undressed in order to give this medication. And it can be embarrassing, particularly for adults, to think about getting a rectal medication. It is very effective. So this is from one of the initial trials of the rectal diazepam versus no medication, just a placebo medication. And you can see this is the number of people who remain seizure-free if they got the placebo, a salt, basically a sugar pill as a medication. And you can see that by about 4 hours, nearly 80% of the people had had another seizure. So in seizure clusters, if people don't get a rescue medication, they're very, very likely to have another seizure. On the other hand, if the people got the diazepam, then only about 65% of them had another seizure within, only about 35% of them had another seizure within that 4-hour time period. So many people were protected from having another seizure. So there are several new drugs for seizure clusters. The first is a medication called Nasolam. This is a midazolam, another benzodiazepine, given as a nasal spray. And it is approved by the Food and Drug Administration to be given for seizure clusters in patients with epilepsy who are older than age 12. And it can be given either during the cluster or after any seizure in the cluster. So